Morning, Dr. Brinson. And then we also have Dr. Siegfried. Good morning. One, three. We have 3 board members present so far that I can see. Dr. Catalano, Dr. Siegfried, and then also Dr. Brinton. We need 3 more to have quorum.
Are we ready to get started yet? Okay, that works. Well, welcome. Happy August 13th. Do we have a quorum? Yes, great, excellent. All right, so there's a reminder in the agenda to update contact information via Google Chat or email. So if your contact info has changed, please do so. Any other housekeeping items from the Department of Health?
This is Jen. There are no housekeeping items to update the committee with at this time.
Okay, perfect.
Yep, thank you.
Yeah. All right. Then we have the approval of minutes. As I was going through the minutes, I noticed a couple things. First, some changes, but also in the chat box, everything you put in there will show up in the minutes, including smiley face emojis and things like that. So just so you know. So as I was looking through, I've noticed my name's in there twice, and Kumar is the chair according to the minutes. So I have to make that change. Any other changes? Hearing none, is there a motion to approve them?
To approve.
This is
Michelle.
Okay, is there, thank you. Is there a second?
This is Kyle. I second.
Thank you. All right, sorry. All in favor of approving the minutes with the changes, say aye.
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 Okay, the minutes are approved. Thank you. All right, the next item is prior authorization form review for Hemlibra.
Hey, yeah, perfect, sweet. I will present that right now. I believe you guys already started this last month. So I will show you the changes or the finalized document after we sent it over to the Hemophilia Treatment Center, and they approved it. So we just wanted to bring it to you guys' attention as an FYI. So once I'm able to, we got like too many tabs maybe. So we may have to do this route then. Hemlibra will present that.
And I'll just note while Mo is bringing that document up that we had both the pediatric and the adult treatment centers weigh in on this form. So
Great.
Yeah, so we did simplify it a little bit more, and we focused on the diagnosis and then also more about patient education, and then making sure the patient does have an adequate amount supplied for acute bleeding when using Hemlibra. And then also for patients with inhibitors, we just wanted to make sure there was a plan in place whenever you do plan to discontinue the prothrombin complex concentrates, and then also a plan regarding patient education to manage acute bleeding.
Great. All right, so the plan is to approve this with those changes, is that correct?
Yeah.
Okay. Anybody have any questions, comments?
You guys can see the document, correct?
Mm-hmm.
Okay, cool. Just want to double check.
Yep.
All right.
Yeah, I don't have any.
Perfect.
I think it was really clear and simplified is nice. Thank you.
No problem.
Mhm.
Thank you, guys. All right. So then we'll move on to the next one. Let's see. We'll bring up the next form, and that is a rare disease form. This one we try to just focus on just making sure that the drug was actually being used according to package labeling, and then if the prescriber's going about the appropriate monitoring that was provided in the package labeling. So we try to do that and try to just keep it simplified, because there are many drugs that do come to market that are orphan drug use, and we wanted to just create an avenue for prescribers to have that. And then when they do submit prior authorization, we just wanted to make sure they hit all the documents that we would look for initially if we do have a prior authorization. So let me present that now. Do you guys see that? Perfect.
Yep.
So some drugs that do come to market, they require sometimes a specialist. And so we wanted to make that if that was applicable. And then documented diagnosis to make sure the medication is being used appropriately, once again, based on the package labeling. And then we also wanted to go about just guidelines or companion treatment recommendations to make sure that they're using the drug at an appropriate timeline. There's different stages. And so we want to make sure they use appropriate medications at the very beginning on stage 1. And then when it does come to that severity, and they could use a medication at that appropriate step. So that's why we recommended just using the latest guidelines that they're able to get, and then follow the FDA approved labeling. And that includes the dosing, weight dosing, and so forth. And then going back to the guidelines, current treatment, standard recommends other treatment modalities like I recommended if it was at the earlier. And then if it is off-label, if like case studies are available and these major journal articles or other smaller articles that are available, they could present that. If it's for a different outside of a certain patient age group or outside for a different condition that's not documented on the package insert.
Can I ask a question?
Yes, of course.
I guess I'm wondering about why the specific journal name call outs. Can it just be a peer-reviewed specialty medical journal?
That's a great question. I know we've had this multiple times in the previous prior authorization, so we've continued that. But prior to when it was established, I can't really speak to that because I'm not aware of like why those certain journals were picked over other ones. But I don't know if the other team members have anything to say to that, or Jen.
Yeah, I mean, I would just comment. I think that's a good point, Catherine. The one thing that I think is for the rare diseases, I mean, you may not get one of your major headline journals
Yeah.
that's going to publish an article on, a case series or something like that for
Right.
rare conditions. So, but this is kind of our canned language that we use to just, when we request peer-reviewed literature, we always use those. I'm happy to have the board discuss that language and recommend other language if that's something, that catches your attention and you feel may not apply. The one, or we could remove it and apply other language, like that would be more broadly applicable to this. I think the one point is we do try to keep canned language with all of our requests that talk about secondary or primary literature to support it. So whatever we would pick for this particular PA would need to be applied to our other PAs.
Right.
I just think, though, as Catherine points out, it means the same thing. It's, I mean, you're saying these specific 3 journals or other peer-reviewed journals, so it doesn't limit it, but it is kind of funny to call them out.
Yeah, I was just going to say, you've got it covered in like what your language here. I mean, you've listed 3, but you're basically accepting anything, correct?
Mm-hmm.
I agree with the discussion. I've always wondered about that language, even on the other prior auth forms that have been through committee. I'd be curious on the University of Utah's pharmacists who are helping with our drug reviews, what their general sense is, where they're pulling from. I mean, are they pulling predominantly from these journals, or are they pulling from a larger swath of journals? And it seems they're pulling from a much larger swath of journals, and there's not a need to call these out specifically.
Is Valerie on? Can you comment if you are?
Yeah, I'm here. I would agree with that comment, especially with rare disease. You know, I probably see more that aren't from those journals, or maybe even, yeah, mostly specialty journals.
Okay, so is the sense that we take out the specific journal callouts and leave the rest of the language?
You know, I wouldn't take it out. I like the fact that they're called out, because I think you're directing people to say, we want information from a reputable journal, and you're giving them a few examples as to what those might be, but you're not saying it has to be one of those 3. And so, to some degree, I guess it reinforces we're looking for evidence that would appear in a journal similar to these, but at the same time, you're not being required to do that. And so, I actually like it how it is, but I'm not opposed to changing it. I feel a little bit for Jen, knowing that they'd have to change language in all of their PAs where they put this language if we were to make that change. And so,
and I agree with Eric. I like the fact that it kind of gives you that sense of like, this needs to be a reputable journal.
Mm-hmm.
And then with the or other peer review specialty medical journals gives you that attachment net.
Mm-hmm.
Well, and from the standpoint of someone who reviews PAs or can represent the team of pharmacists that reviews PAs, I think there have been kind of, junk resources submitted before, or resources that aren't high enough quality to justify recommending certain drugs. So to the point of what Elizabeth and Eric are saying, that is exactly why those were called out, to give a little, at least a standard.
Mm-hmm. Go ahead, Kumar.
Yeah, we can say such as, and we insert the word such as, and that's good because it meets what Eric said and what I just heard. Because such as says that journal of such reputation, and then we give an example, and that's an example. And a couple of words we can just insert.
I think we'd have to rework the sentence to put in such as.
Okay.
Just because of the way it's phrased there.
That's fine.
Yeah.
I would say leave it as it is, just for the sake of all the prior auth forms.
Mm-hmm. Yeah, and having a better understanding of why it's there and what you've been receiving or have received is helpful. So are we now leaning towards leaving it.
I think we should leave it.
Okay. Thanks, Neil.
Totally comfortable on administrative burden.
Okay, yeah.
Yeah, I'm good with leaving it. Is this something we need to vote on, or
Yeah.
I move that we leave it as worded? This is Kyle.
Okay. So are we voting on the whole document then?
Yeah, I'm good with all of it. If we're ready, if we're at that point.
Okay.
Motion to approve document as is.
Okay, great. Second?
I'll
Kumar?
second that. This is Neil.
Okay. All in favor, say aye.
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 All right, thank you. And let's see, what else do we have here? Okay, so that moves us to the next item, which is biological treatments for asthma.
Hi. Yeah, I'm going to share some slides with you. Let me do that. Can you see the slides?
Yes.
Okay, perfect. Yeah. Right. Okay, so this table that you can see here displays the 5 monoclonal antibodies currently approved as add-on maintenance therapy for asthma in patients with eosinophilic or allergic phenotypes or with dependence on oral corticosteroid therapy. These agents include 3 interleukin-5 antagonists, benralizumab, mepolizumab, and ruzasvir, and interleukin-4 receptor antagonist dupilumab, and an immune globulin E antagonist omalizumab. Dupilumab and omalizumab are approved for moderate to severe asthma, dupilumab for eosinophilic phenotype or oral corticosteroid-dependent asthma, and omalizumab for allergic phenotype. Benralizumab, mepolizumab, and ruzasvir are specifically approved for severe eosinophilic asthma. Ruzasvir is approved in adults only, and the others are approved in adults and pediatric patients of varied ages, depending on the product. Additional approved indications include moderate to severe atopic dermatitis and chronic rhinosinusitis with nasal polyposis for dupilumab, eosinophilic granulomatosis with polyangiitis for mepolizumab, and chronic idiopathic urticaria for omalizumab. The age for approval varies depending on the indication. All biological treatments are administered subcutaneously except ruzasvir that is administered intravenously only. Benralizumab, dupilumab, and mepolizumab may be self-administered, while omalizumab and ruzasvir should be administered by a healthcare professional due to the risk of anaphylaxis. As shown in this table, the 2020 Global Initiative for Asthma, or GINA guideline, includes 5 treatment steps based on asthma severity. Regarding severe asthma, step 4 therapy generally includes medium dose inhaled corticosteroid, or ICS, plus long-acting beta-2 agonist, or LABA, as the preferred controller option. High-dose ICS, add-on tiotropium, or add-on leukotriene receptor antagonists are alternative controller options. Step 5 therapy consists of a high-dose ICS plus LABA and referral to a specialist or severe asthma clinic is recommended for phenotypic evaluation. Add-on therapy with biologics, tiotropium, or azithromycin can be considered. The addition of low-dose oral corticosteroid is a secondary option in step 5. The GINA guideline currently recommends add-on biologic treatment specifically for patients who have exacerbations or poor symptom control despite treatment with high-dose ICS plus LABA, and who have allergic or eosinophilic biomarkers or who depend on maintenance oral corticosteroid. Regarding the treatment of asthma, prior authorization criteria for these biologics may require that the patient meet the approved indication for the specific product according to asthma phenotype, severity, and age. Trial and failure or contraindication to at least high-dose ICS plus LABA, and prescription by or in consultation with a specialist with expertise in treating severe asthma may also be required. Omalizumab criteria may additionally require a minimum baseline Ig level of 30 international units per milliliter and minimum body weight of 20 kilograms based on the prescribing information. Initial reauthorization criteria for all biological treatments for asthma patients may include documentation or attestation of positive response to add-on biological therapy after at least 4 months of therapy. Clinical response may be reevaluated every 3 to 6 months thereafter. Regarding their other approved indications, dupilumab PA criteria may include patients 6 years or older with diagnosis of moderate to severe atopic dermatitis and require trial and failure or contraindication to at least topical prescription therapies, including topical corticosteroids, topical calcineurin inhibitors, and or phototherapy. Regarding the treatment of adults with chronic rhinosinusitis with nasal polyposis with dupilumab, PA criteria may require documentation for this diagnosis and trial and failure of 1 topical intranasal corticosteroid, 1 anti-leukotriene therapy, and a short course of an oral corticosteroid based on treatment guidelines. Mepolizumab PA criteria can include adults with eosinophilic granulomatosis with polyangiitis and may require trial and failure or contraindication to at least systemic corticosteroids. And finally, PA criteria for omalizumab may allow use in patients at least 12 years of age with chronic idiopathic urticaria and require trial and failure of at least H1 antihistamine. Alternatively, trial and failure of additional regimens proposed in the 2014 American guideline can be considered. And this is all I have for today. Thank you.
Sweet. Okay, thank you again. I will present the changes that were made and then for the prior authorization. Okay. So let me zoom in. So this one, we actually included all the products at the very top. So we started doing this new document. It's the coverage resources. And so that allows, it's like a searchable document for providers to quickly just Control F and find the brand name. And then from there, it will show you the, the edits and then also a specific prior authorization if it is available. And so this one, we put all the brand names there and then we created a table regarding a condensed table, try to shorten the indications there. There were two that were kind of difficult, and that was moderate to severe persistent asthma. As you can see, we have a couple asterisks there and there, but we detailed it right below the table. What we wanted to point out here is for the drug, the age criteria, and then also the other indications that it does have. And so we did put out there. For majority of the ones that would be requested is going to be for asthma, and we have the criteria right below here. There were changes done to that since the last time I actually sent it out. And so we still require a specialist, and then making sure they selected the actual diagnosis at the very top from the table. They could do a regular circle over it, or they could just type in the diagnosis here. The next one is what the member currently takes at that time of requesting, because it was recommended by the GINA guidelines that this is a step 5. And so when they start using these biologics, so we want to make sure that they have properly gone up the steps. And then we also require at least one high dose or a contraindication to a high dose of a corticosteroid and a long-acting beta agonist combination for at least a minimum of 3 months, like how it was recommended. And then we also see that patients could have an add-on to tiotropium or leukotriene receptor antagonist therapy, and that's what we also saw in the GINA guidelines that were presented. So we did add that, and then we also added a baseline eosinophil value, just to attestation that the provider has obtained that, and they're looking at that as well. For more specific indications we are listed down below. So we have additional criteria for Dupixent, and then from there, going back is chronic rhinosinusitis with nasal polypsis. Once again, having a trial failure of a nasal corticosteroid within the past year, and then also failure or contraindication to oral corticosteroid in the past year. And that's what we also saw in the guidelines or the report that was presented. For moderate to severe chronic atopic dermatitis, on this one, we just recommend to have at least one high potency topical corticosteroid, and then one topical immunomodulator, and then at least one listed oral systemic immunosuppressive therapy. And then the last two for Nucala, specifically for the eosinophilic granulomatosis with polyangiitis or EPGA. We did just recommend a trial failure or contraindication to oral corticosteroid, which we saw that was in the report as well. For Xolair, we recommended to have the IgE value because the dosing is based on that and also the weight. And that's also seen in the package insert. So we recommended to make sure they have the appropriate dose. So whenever they do submit it, we were able to quickly check to make sure it's within that specific category that they're able to get. And then the last one is a chronic idiopathic urticaria. And then this one, usually a specialist is already going to use a beginning treatment such as the first generation antihistamine, second generation antihistamine. So we just require additional add-on therapy to that, whether it's an H2 antagonist or a leukotriene receptor antagonist. No, we did have a comment. 1 second. I'm wondering if it was. Okay, so was it case reviewers include a date of the chart note when you ask the page number that you are reviewing the correct.
That would be helpful.
Yeah.
That was relevant maybe in the last PA as well, and probably just as a practice throughout. It just seems there's often more than one chart note,
Right.
at least in the reviews I do, and it's sometimes very hard to figure out where we're actually trying to find the information. I do wonder also on the eosinophil count, same kind of thing. You know, if you're going to ask for it, you may want to just ask for the value and the date, because again, if it's something you're asking for as a baseline, they could have done it a year ago, and that's not really a baseline, right? And so just as a verification step that it's actually a recent value, or an informative value related to the place that the patient is in the course of treatment.
Okay, you could definitely put that in there, add the value to that.
And date.
Date. Let me just quickly.
I got it, Mo.
Perfect. Value, and then we'll put.
So it's the date of the chart note or test, just to confirm, Dr. Hoffman.
Yeah. Just to.
I think that's very helpful.
A lot of places where we're asking for chart note page, I think date of chart note and page number would be just a nice way to.
Thank you. And we are always looking for those dates, so thank you.
And we'll correct that with the other ones. Just like that.
That's good.
Is there any other questions?
I have a comment on the atopic dermatitis.
For Dupixent.
For Dupixent, yeah. You have or contraindication for steroids and topical immunomodulators, but not for systemic immunosuppressive.
Yeah, so on this one, our thought process was, since we list out, there's 4 options available. You can have a contraindication to one, but there's still 3 other treatments are available. And since we listed out, we wanted to see if they could at least try a different therapy there.
I mean, I haven't looked at atopic dermatitis guidelines in a little bit, but are they really like preferred over Dupixent at this point in time?
It's a great question. Elena, did you guys see anything on that one?
So do you mean if the oral immunomodulators are preferred over Dupixent?
Yeah, after failure of the topical steroids and the topical immunomodulators.
The guidelines are from 2014, and they don't really include Dupixent at this point. They recommend, I mean, they follow this structure. Is more first topical corticosteroids, then you go to the second line treatment, which is topical immune modulators, and then you go to systemic options that I guess could be a systemic immunosuppressive, or Dupixent. But they don't really. We would need to check if there are like head-to-head comparisons between systemic immunosuppressive therapy and Dupixent. And the guidelines are from 2014, so they don't really mention Dupixent. There's another guideline. I think it was a European guideline. Let me check that very quick. Yeah, there's a 2018 European guideline recommending Dupixent in patients where topical treatment is not sufficient and other systemic treatment is not advisable. So maybe, yeah, I think it could be reasonable, I think, to have them.
Yeah, I just hate to make people walk through all these systemic immunosuppressants with lots of toxicities before being able to access this drug, you know?
Yes, I agree with that. I think, yeah, for sure. I mean, I guess the patient should try and fail topical corticosteroids, then topical immunomodulators. But I'm not sure about the third option because there's not a lot of information about that. But yeah, I agree with that. I agree with the toxicities related to these agents. Yeah.
You know, though, there's a lot of people that tolerate those therapies just fine. And so I guess given some of the cost differentials that exist between these products and kind of are making sure that people have tried the most appropriate therapies, rather than just eliminate them, and nobody's going to disagree that some of the side effects associated with the products are.
I would agree with that if there was really good research behind those, but I don't believe there is.
Then list the reasons why they're not appropriate. And if you're not going to try one of them, then give us a reason why you don't want to do it.
Or how about if they just fail one versus walking through four, you know?
It's just at least one.
At least one. Okay. Yeah.
Yeah, no, we would have
That's
required
still
them to
like,
go all four. Yeah.
yeah. I mean, you take agents without, go ahead.
Well, the wording could be changed to trial and failure or contraindicate, of at least one, or contraindication to the oral systemic immunosuppressive therapy. And then you would have
that
to,
absolutely covers it.
that way, that would give the prescriber the ability to, basically just, discuss their thought process as to why they would not want to use these agents in favor of Dupixent, for example.
Right.
And quite honestly, I guess I get the sense sometimes that providers are just not quite sure what to do, and rather than have them just immediately jump to Dupixent, I'd love to understand at least there was some thought process that was made, and they can document that on a piece of paper.
Point of clarification, this is Joe. Does the committee recommend they meet all three of those criteria under chronic atopic dermatitis?
I feel like the first two, yes, but I'm not sure on the third one.
Okay, thank you.
So Joe, that's 2 of 3. You big Cottonwood Canyon guys, you may not catch that, so I thought it was funny.
That's pretty complicated math. I appreciate that.
Definitely. So you would like to have like a section where they could just provide some clinical rationale why this therapy is not appropriate, correct?
Yes.
I think it could be with the chart note page also, same kind of thing you did as above. If, they want to contraindication in the chart note or on this PA form in a particular place you identify. But
yeah, we'll probably add a line right below this to say if contraindication, please provide clinical rationale, and then chart note page. But I will put that down here.
I've got it, Timo.
Oh, you do? Okay, perfect. So yeah, you can put that one. I'll just quickly. Then we'll have that. Okay.
what Susan brings up really a best practice that we've talked about on several other PA forms, so it just might be worth considering as canned language in the future around when you step through.
Yeah. We'll craft something up for that one, and then we could try to use it for the new PAs that do come through. And then also revisit the old ones and make sure we could have that canned language there as well.
So in that case, do we need the date of use, length of therapy for each of those, or can we just list them as examples of systemic immunosuppressive therapy?
I don't know. It could be if a provider's filling out, they just select that one product. They could go either way. Yeah, you're right. I thought it was just easier for them to find that product, list it there, and then they can move on. It does shorten it, but once again, it will shorten it. We'll short it to 2 pages, so it still will come out to 2 pages in the end.
Yeah.
But I'm fine with either. I thought just in provider use, they could find the product. Okay, here it is, date of use, in there, instead of trying to list out another one, the entire product, and then from there provide a date of use and then length of therapy. Just one additional step. That's it.
Okay.
Is there any other changes or other recommendations for this one? We're still crafting up that language, but we'll have something.
Okay. So we will wait to approve it.
Yeah, that could, Joe, quick question. Have you got that language?
I think so, but I'd love it restated, please.
All right. Dr. Hoffman, I know you recommended a specific language, or even Dr. Siegfried, I know you guys are tag teaming there for a certain language. What was that language again, if you could repeat that?
Well, I think, the way it's written right now, I would just say to provide the clinical rationale in the chart note and then list date of chart note and page number, and then you go to that. So if contraindication, provide clinical rationale in chart note, period, date of chart note and page number. And then you've got, I think that, that's what I would recommend.
Thank you.
We need to still include public comment on this. We have for one of the medications, correct?
Yes, we did receive a comment request yesterday, so we do have that still.
Okay, why don't we take care of that now then?
Yeah, good call, good call. And so we do have one. And let me.
Hello?
Yes.
Yep, we can hear you.
Oh, great. Thank you. Good morning. My name is Maria Gopova, Senior Medical Outcomes Liaison at Teva Pharmaceuticals. And I'd like to provide some additional information on Syncare injection. For full information, refer to the prescribing information. Just an update to the existing data that may have already been part of your package. 2 additional post hoc analyses looking at specific subpopulations. One is the oral corticosteroid dependent patients, and the other is the high body weight patients. And the distillation of that is that in the subset of oral corticosteroid dependent patients, risankizumab treated patients had lower mean cumulative systemic corticosteroid dose per patient compared to those with placebo. And then the second analysis with looking at baseline body weight and weight-based intravenous risankizumab dosing, we just found that among adults in the subgroup with the highest baseline body weight, risankizumab resulted in a 50% reduction over the 52-week, so a year treatment period as compared to the overall population, which was at 44%. In terms of the overall population, it experienced similar result in the mean number of clinical asthma exacerbations with risankizumab compared to placebo. And the only reason that's important is because of the association between obesity and severe asthma. We want to make sure that efficacy and safety is shown in that patient population. So in conclusion, this information adds to the already existing body of evidence in support of Syncare, and we appreciate the committee facilitating for Utah prescribers the choice in biologic treatment for severe eosinophilic asthma that best suits the needs of their patients. Thank you very much for your time.
Thank you. Any questions from the committee? Okay. All right, have we kind of gone through enough of the prior authorization? Do we need to look back at that again, or are we good?
I think it looks good.
Can you pull it back up on the screen?
Yeah, doing it right now.
Okay. Okay, can you scroll down a little more?
Yeah. Let me know when you want me to stop.
Okay.
And then the last page is just a quick signature there.
Okay.
But we'll condense it to 2 pages there.
All right, so are you looking for approval?
Yes, please.
Okay, is there a motion to approve?
I'll move to approve. This is Michelle Hoffman.
Thank you. Is there a second?
I'll second it.
Okay, thank you. What's that?
I said I'll second it, but Kumar had his hand up. So.
Okay, yes. Noted. Saw that. All right, all in favor, say aye.
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 Any opposed? All right, thanks. Good stuff. Moving on to adjourning. No?
Yeah.
Okay, is there a motion to adjourn?
Move to adjourn. I'm all over that.
I'll second.
All in favor?
It's good to you all.
Aye.
Aye. All
Wow.
right, thank you, everyone. Enjoy
Thank
the
you.
rest of your summer. Stay cool. Stay
Thank you
healthy.
again for everyone. Really appreciate you guys' help with everything.
Thank you. Bye.
Great.
Thank
Bye.
you. Bye.
No problem. If anyone has any comments, I'll be waiting behind.